Hi, good morning, everyone. Welcome to 149th weekly Cmaao session. We are here meeting for a very important topic. We all have seen recently conjunctivitis is one of the major issues which is happening. It could be because of the rainy season. It could be because of infection being spreading. So today, to discuss this topic on this important forum, we have Dr. Vishali Vijay Varad. She will be talking about an approach to red eye. People who want to join this session, I know this session is also important for patients and general public. If you guys want to join this session, you can come on Zoom. The session is the Zoom meeting ID is 818-8591-1572. I repeat, 818-8591-1572. Uh, Dr. Vishali has done a fellowship in cataract surgery, eye disease, squint, retina, and glaucoma from one of the top international famous eye institute, Lakshmi Eye Institute. She has done a DNB from Mumbai University under the care of Dr. R.C. Patel, who has been internationally renowned eye specialist in Mumbai Hospital Institute of Medical Sciences. She has done a glaucoma fellowship from Arvind Eye Institute. She has done a retina fellowship in Desai Eye Hospital. She's a consultant and director at Sai Netrila and Specialty Clinic in Pune, and she has over a decade experience. Over to you, ma'am. Please enlighten us with the important topic.
Good morning, everyone. Thanks for the kind introduction, and thank you for the wonderful opportunity. I'll be sharing my slide.
Thank you.
Visible?
Yes, ma'am, it is visible.
Yeah.
Please go ahead.
So I'll be talking on approach to red eye. So why this is important? Just a minute, it's not moving. Maybe. Okay, so why it is important to know about the red eyes or the causes of the red eye in the details, because this is a frequent or the common complaint that patient comes to a general practitioner and it can be related to mild ocular diseases or it can be related to vision threatening diseases. So this is very important to diagnose or to give a primary treatment and to pick up the red flag signs as early as possible and guide patient according to that to visit an ophthalmologist to have a detailed eye checkup. As we all are aware, ophthalmology itself, super specialty branch, it needs and microscopic examination or slit lamp examination to see the deeper structure, because with a torchlight examination, we are not able to see the deeper structures involved in the diseases. So this is a very important topic that we are discussing today. Before going to the causes and differential diagnosis of the red eye, this is a basic anatomy of a eye. These are the lid, upper and lower lid. So these act as a protective layer to prevent, or it takes everything on it, trauma or foreign body, and it protect the eyeball from the injury. So then this is in cornea, then conjunctiva. Conjunctiva, it starts from the cornea to the posterior surface of the eyelid. Then is in all external structures. Then internally there is an iris. There is a central aperture called as an pupil. Behind the pupil there is a lens, and then there is an vitreous, retina, choroid, and sclera. And of course, optic nerve, which goes to meet brain posterior. So this is a basic anatomy of an eye. Coming to a differential diagnosis of red eye, always start to examine from anterior to posterior. So first structure that we see is an eyelid. So diseases related to lid, patient can present with a redness of an eye. It can or cannot, or it may or may not be associated with a pain or the discharge. Then other causes are related to conjunctiva, cornea, then other structures, retina, uvea. It can be related to trauma and foreign body. So we'll see one by one. how patient it looks like and how patient present with and these all different diseases with redness and associated complaints. So first, lid. So blepharitis, it is more seen in an adult than a children, but it can be seen in adults and children also. This is an inflammation of lid margin. According to anatomical in position, it is anterior blepharitis and posterior or the meibomian gland dysfunction. Then anterior blepharitis can be associated with stye. So while managing this patient, this is how anterior blepharitis look like. This is present anterior to the gray line of a lid. This is an posterior blepharitis present posterior to the gray line of a eyelid. So the anterior blepharitis, again, it can be a simple blepharitis or it can be associated with parasitic infections such as Demodex. And the posterior blepharitis, it cause an inflammation of a meibomian gland duct, causing a redness of an eye. These blepharitis is associated with an itching, burning sensation, sometimes dryness of an eyes, along with a redness of eye. So this is a sky how it looks like. Sky, it is in red and painful lump near the edge of the eyelid. So here there is an inflammation of the eye follicle of an eyelash. So this is how patient will present to us. Then there is another form of sty that is an internal hardylium or the internal sty. And here there is this swelling and redness from the which presents or which comes in the inner side of an eyelid. So treatment need here is an hot fermentation. We may need to give an systemic antibiotic to reduce the inflammation, acute inflammation. Sometimes it non-steroidal anti-inflammatory medicines and topically antibiotic also we may need to give. So this is about the blepharitis. And related to an lid malpositions. One is this is an entropion, this is an ectropion. So what is entropion is interning of an eyelid margin. So because of the interning, you can see these lattice, these rubs to the ocular surface causing a redness of an eye. This is an ectropion, this is an outturning of an this leads to an of an ocular surface causing redness, dryness, and other complaints also. So management required in these conditions is of course, surgical management. Then coming to an conjunctivitis. Now it is conjunctivitis is very much going on, at least in India, it is very much going on as this is in rainy season. So there are basically viral types of conjunctivitis are viral conjunctivitis, bacterial conjunctivitis, and allergic conjunctivitis. Viral conjunctivitis, patient comes to us with an acute redness, watering, with a foreign body sensation or a pricking sensation. Sometimes this can be associated with mild to moderate swelling of an eyelids. So on examination, there is a conjunctival condition or conjunctiva is intensely hyperemic, and there may be an presence of follicles or the hemorrhage that is called as an hemorrhagic conjunctivitis. Or there can be an inflammatory membrane also on at a phonesis or at a tarsal plate. So this is sometimes associated with preauricular lymph nodes. Patient, if you ask patient whether do you get a pain here at a preauricular region, so or you can palpate also. This is associated with preauricular lymphadenopathy. And most common cause of an viral conjunctivitis is adenoviral infections. So treatment required here is an assurance to patient, then cold compressions. Then we can give a mild antibiotic to prevent the secondary infections and lubricating eye drops. It also helps to, wash the discharge and patient feels comfortable with the lubricants. So this is a difference between a bacterial and viral conjunctivitis. So in a bacterial conjunctivitis, discharge is mucopurulent to purulent discharge. In a viral conjunctivitis, discharge is watery. Bacterial conjunctivitis is generally bilateral. Viral may present with an unilateral, but other eye can involve between 10 to 12 days at any time. Then This may be associated with hepatitis media, and viral conjunctivitis is associated with meningitis. We call it as conjunctival fever. Then adenopathy is present in a viral conjunctivitis, but it is not present in a bacterial conjunctivitis. So then this is how follicles look like. This is how membrane. There are two types of membrane. One is in pseudomembrane and second one is true membrane. Pseudomembrane we can easily fill up with the forceps. True membrane, it bleeds once if you try to peel the membrane. So this is how viral conjunctivitis looks like. Then coming to bacterial conjunctivitis. Again, it can involve adult and children. Complaints, watery or the mucopurulent to purulent discharge, then foreign body sensation, burning of our eyes. Then there is an edema, lid, and conjunctiva also maybe an edematous. Most common organism causing an bacterial conjunctivitis is Streptococcus pneumoniae or Staphylococcus aureus. The treatment needed here is a broad spectrum antibiotic. So you can also see in the conjunctival solve for cultural sensitivity. Here, mainstay of a treatment is in bacterial conjunctivitis. Along with that, supplementary treatment like in cold fermentation, frequently cleaning of an eye, and lubricating eye drops. And difference between a viral and bacterial conjunctivitis, I have already explained about this is a features of a viral conjunctivitis. So coming to an allergic conjunctivitis. So allergic conjunctivitis, it has a spectrum of varieties to present with. It can present with a mild but a disturbing form and severe, which can be a vision threatening also. So allergic conjunctivitis, it needs a thorough examination with a slit lamp to see the grade of an allergic conjunctivitis. It is mild, moderate, or severe allergic conjunctivitis. So in a history, main complaint in allergic conjunctivitis is an itching. In viral and bacterial, patient will see there is a foreign body or pricking sensation. But in allergic conjunctivitis, this is associated with the itching or eye rubbing. Also, there is an history of rhinitis, asthma, or other atopic diseases, or family history of atopy is always present in allergic conjunctivitis. So in these signs, patient may have a mild redness of eyes, then discharge. Mainly this is a watery and a ropey kind of discharge. So this is in whitish instead of a yellowish color in a bacterial conjunctivitis. So this is a ropey discharge patient can complain with. This is how chemosis will look like. This is an edematous conjunctiva called as a chemosis. And patients present with an papillary hypertrophy. It can be around limbus also and at a tarsal also. And which kind papilla, the combustion appearance of a papilla. This is because of an inflammatory response of a tarsal plate. There is a difference in a papilla and follicle. Follicle is a sign of an viral conjunctivitis. Papillae is a sign of an allergic conjunctivitis. So papillae is an inflammatory. So here generally is a red and base is a pale. And in a follicle, it occurs because of the collection of WBC. So there is an absence of an blood vessels with the capillaries. So top is pale in a follicular conjunctivitis. Treatment here, it again needs depending upon the severity of disease, and basically root cause management we should always think about by detecting the causative allergen that causes an allergic conjunctivitis. So after detection of an allergen, we can guide patient for the avoidance. Avoidance is the disease modifying or can change the course of a disease. And some allergens we cannot avoid in our day-to-day life, just like a dust mite group of allergens or pollens. We cannot sit at home by closing our window all the time to prevent exposure to the allergens. So these patients need to undergo desensitization by an immunotherapy. Again, there are two types of immunotherapy available. One is injectable and second one is an oral sublingual immunotherapy. Along with that, ocular management is also important. So allergic conjunctivitis needs systemic management also, as well as ocular management also. So ocular management we can do by giving an antihistaminic drops. mast cell stabilizer drop. Topical corticosteroids are a mainstay of an allergic diseases, and then the cyclosporin eye drop. See, while giving topical corticosteroids, always ask guide patients about the side effects of the steroid also, because if patient feels better with that drop, they will continue the same drop again and again to get an symptomatic relief, or sometimes over the counter medicines also very much given to in such diseases. So patient can present with complications related to conjunctivitis as well as complications related to medicines. Complications related to medicine is because of the overuse of the steroids, and patient can comes with a steroid-induced glaucoma or steroid-induced cataract. So, what are the ocular complications of an allergic conjunctivitis? This is an Shields ulcer. Why this Shields ulcer happens? Because of the gelling papillae, which are present here at the tarsal plate. So, with every blink, it rubs on your cornea and it disturbs the superior epithelial layer of the cornea, causing a Shields ulcer. Sometimes patients can have a just superficial punctate keratitis, that is an SP case, but patient can go in a Shields ulcer. If we don't treat this with an urgent management, then this can infect badly to, sometimes we need to, a patient may have individual treatment complications also. This is how limbal cell deficiency can happen in an allergic conjunctivitis. What is limbal cell deficiency? Limbal cells are present around at the limbus. So because of the repeated inflammation that happens in limbal cell deficiency leads to such type of pannus and corneal opacification. So again, this needs a surgical intervention for the management. Then, even though patient is not having that much of redness of eye, but associated with an eye rubbing, or the patient complains of frequent eye rubbing, these patients may go in a complication such as in keratoconus. So what is keratoconus is, this is in cornea, which has an convex shape, but because of the rubbing, there occurs the thinning of an corneal layers, and cornea becomes a conical shape, so causing an irregular astigmatism. So sometimes it becomes so thin that there occurs the rupture of an endodesment membrane, which is the inner structure of an cornea. Cornea has 5 layers of an anatomical 5 layers. So inside layer is an descent membranes, which gets ruptured, and aqueous humor gets entry into the inside of an corneal layer, causing an acute hair drops. So if we diagnose this at early phase, we can manage with a different kind of management, such as contact lenses, rigid contact lenses, sometimes scleral contact lenses, or we may need collagen cross-linking, or we can do collagen cross-linking to prevent the further progress of keratoconus. But in severe cases, we may need to transplant the cornea, or penetrating keratoplasty also we need to perform. So even early detection and early diagnosis by a thorough ophthalmic examination, we can prevent such type of complications in allergic conjunctivitis. So this is a compiled picture of an all conjunctivitis. This is what you see: papilla in allergic conjunctivitis, follicle in a viral conjunctivitis, type of copious purulent discharge in cases of a bacterial conjunctivitis. Chemosis is, again, we can get it in a allergic conjunctivitis, and redness is an depending upon the severity of disease, redness is present in all type of conjunctivitis. So this is all about the conjunctivitis. Then coming to another cause of a redness of eye, subconjunctival hemorrhage. It can be diffused or localized. So here, this is a localized, this is a diffused. So there are different causes of a subconjunctival hemorrhage. Is in trauma. It can be because of a severe cough or just sneezing. But what most importantly is, always ask these patients about using a blood thinners. If they are on a blood thinners, they can aspirin. Ask them to stop, because patient can go in a cerebral hemorrhage by bleeding through the intracerebral small vessels. So this is about the subconjunctival. Again, we need to see the margin of a subconjunctival hemorrhage. If we see the margin of a subconjunctival hemorrhage. In a head injury, if it is because of the bleeding, this can come in a subconjunctiva or it can show in subconjunctival hemorrhage. So here we cannot trace the margin of subconjunctival hemorrhage. So it is, we can very well pick a bit of, or we can see if it is secondary to the trauma or secondary to the other causes. So treatment required here is mainly a cold fermentation and management of a cause. If it is related to hypertension, we need to control the hypertension. If it is related to use of a blood thinner, we need to stop it. If cough and sneezing, that we need to give a simultaneous treatment of a cough for the along with the help of your physician. And vitamin C has a good role to absorption of blood a little bit earlier. So this is how subconjunctival hemorrhage will look like. Then coming to a dry eye. So our eye is protected with lids and superficial tear film, which is present on an ocular surface. So lacrimal gland is where these tears are secreted with, and every blink, this blink spreads this tear film on an ocular surface evenly. So blink is very important to give a fresh tear layer on your ocular surface, as well as to wash out the toxins which are accumulated on your ocular surfaces. So there are two types of dry eye. One, it is because of the poor quality of and tears, and second one is related to poor quantity of tear fluid. So as I told, tears are secreted from a lacrimal gland. So there are other two layers which are present in a tear film. One is a lipid layer, which is secreted by a meibomian gland, which we see at the margin of a lid, and then goblet cells. These are present on a conjunctiva itself. So lipid layer is secreted by a meibomian glands, and mucin layer is secreted by a goblet cells. If there is a disturbance in any of these three components of a tear film, patient can complain of a dry eye. So how patients comes to us is chronic red eye. Then it can be associated with a burning sensation. Patient himself or herself says that I feel my eyes are dry. After continuous or the more exposure to the computers, at the end of the day, my eye feels tired. That can also one of the presentation of a patient in a dry eye syndromes. So in a poor quality, it is basically due to a meibomian gland diseases. It can be related to vitamin A or deficiency or a D deficiency also. Poor quantity is because of the less secretion of tear film. It happens, that is called as an keratoconjunctival dyscica. It can be, it happens in a Jogren syndrome, rheumatoid arthritis also, or sometimes lacrimal diseases such as sarcoidosis. So how do we manage the dry eyes syndrome? Is first analyze where it is related to poor quantity of a disease, that is an aqueous deficiency, and whether it is a poor quality of a disease, that is called as an evaporated dry eye of diseases. So we can give, and depending upon the severity or depending upon the Sharma's test and tear breakup time, we can give an lubricating drops. Different types of lubricating drops are available, including that includes HPMC, hydroxymethyl cellulose, and CMC, carboxymethyl cellulose, and sodium hyaluronate. So according to severity of eye, we can give a dryness, we can manage the dryness of eye. Cyclosporin has a good role to reduce the inflammation. 0.05% of a cyclosporin topical eye drop has a good role to reduce the inflammation, but we have to prescribe at least two for a long term to have a good effect of it. So this is an teresium. There is an abnormal growth of a subconjunctival tissue over the cornea, causing a teresium. This is how teresium will look like. This needs an surgical management with an excision of a teresium along with a conjunctival graft. And then coming to corneal causes. Before going to corneal or the further causes, I'd just like to explain here the type of conjunctival or the congestion, how it looks like. This is an conjunctival congestion, how it looks like. Vessels are superficial and little broader. These we see it in a conjunctival diseases or the conjunctivitis. Then there is a pericorneal confusion. It again we can see in a corneal foreign body or corneal lesions near the limbus. Then coming a mixed type of the condition. It is associated with the conjunctive condition also and circumciliary condition also. This we see in a corneal ulcers or some intraocular pathology is there. Only ciliary condition. This indicates the involvement of cornea and deeper structures, and there is no involvement of conjunctiva. So this can be seen in a different types of diseases such as the episcleritis, scleritis, keratitis, iritis, and cyclitis. So this is a red flag sign. It is a ciliary condition. That means there is an involvement of other structure than a conjunctiva and needs a thorough examination by an ophthalmologist. So then coming to a conjunctival causes. So corneal abrasion can present with an redness associated with an watering and foreign body sensation and sometimes pain and photophobia. Because of an abrasion, patient has an intense photophobia. Depending upon the severity of abrasion, photophobia, sometimes patient is not able to open their eyes also. So we need to put and paracaine or anesthetic agent to feel comfortable, patient make patient comfortable, and then we can examine the patients under slit lamp. So corneal abrasion, so there is a disturbance in a special layer of a cornea. It can be secondary to a trauma, it can be secondary to the chemical burn, it can be secondary to a rubbing of a foreign body which is present on a tarsal plate. So it gets streamed with a fluorescing to see the. So this is how this corneal abrasion looks like after the fluorescence staining. So this is a superficial layer of a cornea has it disturbed, so causing a corneal abrasion. If foreign body is there at the tarsal plate, it keeps rubbing on the cornea with every blink and leads to an irregular scratches or irregular abrasion of an cornea. So we need to remove the corneal foreign body in these patients. Then coming to an foreign body. Patient can present with redness, watering, and history. Patient may give history that something has, something went in his eye. It can be in corneal foreign body. It can be in tarsal foreign body. So corneal foreign body, we need to remove it under the slit lamp to get a depth perception of a foreign body. This maybe you can remove it under a torchlight. This is a tarsal foreign body. So this keeps on rubbing on the cornea and causing a corneal abrasion. Then coming to a corneal ulcer. So corneal ulcer, it can be bacterial, viral again, herpes simplex, herpes zoster. It can be related to fungus. It can be related to protozoa such as acanthamoeba. And this is mostly common seen in contact lens wearers. So always ask when patients comes to you with a redness, history of a contact lenses, do they use the contact lenses or are they contact lens users? So again, corneal ulcer needs a thorough examination. Under the slit lamp examination, we need to scrap the ulcer. We need to see it for the QA staining and for the further examination, microbiological examination. And we need an management according to the cause of corneal ulcer. If it is a bacterial, then we need to give an broad spectrum antibiotic. If it is a viral, then we need to give, and depending upon the whether it's a epithelial, stromal, or endothelial involvement of endothelium. Again, treatment varies with topical along with topical cyclovir, we may need to give a systemic acid also. And fungal management is different depending upon the severity of corneal ulcer. So this is how corneal ulcer look like in a herpes simplex. Herpes, this dendritic pattern is seen in a herpes simplex corneal ulcer. Herpes zoster also we can get such type of an dendritic pattern that is called as a pseudodendritic pattern. So this is generally at the center of a cornea. In a herpes zoster, we get it at a peripheral lesion or the periphery of a cornea. This is a severe corneal ulcer. How it looks like this. This is a non-infective. This ulcer can be an infective and non-infective. So Murine ulcer or the peripheral ulceral keratitis may be associated with other collagen diseases such as the arthritis or venous granulomatosis. So corneal examination needs a thorough examination. So this is an episcleritis. Episclera is a structure present behind the conjunctiva and above the sclera. So there is an inflammation of a episcleral tissue causing an episcleritis. This can be a nodular, or this can be an diffuse or the localized episcleritis. So these patients present with redness, sometimes associated with a mild pain, and this is generally self-limiting, or patient may need an topical low-dose steroids to control the inflammation. So it can be associated idiopathic, or it can be associated with a collagen vascular disorder. Then sclera, the involvement of sclera or deeper, it is present behind the conjunctiva. So these patients present with an redness associated with pain. So sclera is the site where they are extraocular muscles are inserted on. So if there is an inflammation of an sclera, an scleritis, patient may complain of pain while eye movements. If it is scleritis near the insertion of an muscles, then patient may present with and may complain that there is a pain while ocular movements, or redness is associated with dull pain. So again, causes are different. It can be an idiopathic, or it can be related to an collagen vascular diseases. It can be an infective, and it also needs a thorough examination along with an sometimes systemic management, along with the help of the rheumatologist, with the steroids or with the immunosuppressant also. So this is how scleritis looks like. This is how redness of a scleritis looks like. This is an diffuse scleritis. Because of the repeated scleritis, sclera may get thinned out, causing such type of blackish discoloration. You can see, or the structures below the sclera are visible. So this type of an bluish or the blackish discoloration you can see because of the thinning of the sclera. Then coming to an uvea. Uvea includes iris, retina, and choroid. So these are the posterior structures present in our eye anatomy. It can be an anterior uveitis, posterior uveitis, or it can be an panuveitis. In an anterior uveitis, there is an involvement of iris. In a posterior, there is an involvement of vitreous, retina, and choroid. And in a panuveitis, all structures get involved in the panuveitis. It is anterior and posterior also. Anterior uveitis patient complain along with an redness, photophobia, and this is associated with an decreased vision. So again, photophobia index indicates involvement of deeper structure or the involvement of cornea. So if patient redness, always ask patient whether it is related to intolerance of light, that is a photophobia. That means this is a red flag sign. Then causes again is an idiopathic. They may be associated with an arthropathies or psoriatic arthritis, Ritter's disease, or sometimes it can be associated with autoimmune diseases such as sarcoid disease and Behçet disease. It can be secondary to infections such as toxoplasma, tuberculosis, or the syphilis. So this again need an further evaluation and proper management with an ophthalmologist, sometimes involving other specialties also. So this is how this circumciliary condition look like. I have explained about it before also. So in our iridocyclitis, or whenever there is an involvement of a deeper structure, such type of congestion we get. So you can see here there is not a much congestion, but mostly perilimbal area is congested. KPs we see behind the back part of the cornea. These are the KPs or the exudates. Hypopyon also we can get because of the exudate. So flares and sales, these are the slit lamp findings that we get in iridosclerosis or the uveitis patient. This is in retinitis or the vasculitis. This is in vitritis. Then this is in choroiditis. This is how posterior uveitis looks like, which needs thorough examination with the slit lamp, dilated examination, or the examination with indirect ophthalmoscopy. Then coming to an angle closure glaucoma. Patient can present with an redness with a severe pain headache, and generally headache is so severe, it's a throbbing type of headache, and this is associated with an vomiting because of the raised intraocular pressure. Normal pressure is around 10 to 20 millimeters of mercury. In an acute angle closure glaucoma, patients can pressure can raise above 60 or 70 millimeters of the mercury, and patient can present in a casualty with such type of a complaints. So again, there on torchlight examination also you can see red eye is red. There is an corneal edema, circumciliary congestion, pupil. So this is the most important thing. Pupil, it is non-reacting to the light, and AC is shallow. Pressure you can measure with an digital intraocular pressure. Also you can measure this with the help of the fingers. You need to push your fingers on a ask the patient to look down, and with the finger pressure you can analyze a digital intraocular pressure. So in an acute angle closure glaucoma, pressure is very much high. So this needs an urgent management by reducing an intraocular pressure by giving an IV mannitol, giving an tablet Dimox, and locally you can give an iotin eye drop, or you can give an glycerine to reduce and corneal edema, and you can do a gonioscopy also. So this is how acute angle closure glaucoma patients presents with. So now, in a conclusion, when patients of a redness comes to a general practitioner or in a casualty, always ask about the history of a trauma, history of a contact lens use, whether the redness is present associated with the pain, photophobia, whether it is associated with the vision, significant vision changes or decrease in a vision, or there is any history of a similar episode before. Then on examination, assess the visual acuity, how much you can see in casualty, or Snell's chart is the best way to visual assessment of a vision. Then with the torchlight examination, you can see the type of congestion, how it is, then see the corneal involvement, whether you can you see the foreign body on a cornea, or on the tarsal, you can evert the tarsal plate, then see the pupillary reaction, how it is normal, or it is fixed, dilated, not reacting to light, then see about the tenderness, and then see about whether there is any corneal infiltration, corneal opacity, and measure the intraocular pressure with the finger to assess the regional intraocular pressure. So these are all red flag signs where we need to refer these patients to an ophthalmologist on a urgent basis to salvage the eye or to see the vision of that patient. So in a summary, these are the common causes of redness of an eye that patients presents with: injury, pink eye, again viral, bacterial, then blepharitis, uveitis, again anterior, posterior, allergic conjunctivitis, corneal ulcer, dryness of the eye sty. It can be an external hardyrium, internal hardyrium, then acute glaucoma, episcleritis, subconjunctival hemorrhage, or because infection related to contact lenses also. Sometimes overuse of contact lens can present with a redness of an eye at the end of the day. So this is all about the redness common causes and how when we should, what are the red flag signs and when we should refer it to the ophthalmologist. So thank you. Thanks a lot for patiently listening. Yeah, shall I stop sharing my slides?
Yes, ma'am, you can stop. Thank you so much for the wonderful presentation. And I would like to now invite the member of the forum for the question answers. I also welcome Dr. Chong, who is the chair, and Dr. Wazik, who is the president for Cmaao. Dr. Chong, would you like to go ahead with the question? And yeah.
Hi, thank you, Dr. Rushali Warat, for the wonderful presentation. I tuned in a little bit late, but I caught quite a bit of it, and it's a very, very useful algorithm you've given us without access to a slit lamp, which is so, clinically so useful.
Yeah. Ophthalmology is a super specialty branch, so to diagnose the things with an slit lamp and all.
I don't know whether you mentioned in your presentation, but I usually feel for the pre-auricular node, limb node here, to look for viral conjunctivitis. It's almost like 100% diagnosis.
Yeah. Always ask, or you can palpate the preauricular node here. It's near the pinna of an ear. So this is a sign of a viral conjunctivitis. And these patients may be associated with pharyngitis or the sore throat also.
Yes. I welcome any questions from the floor.
Okay, Saurabh. Chong, how are you?
I'm good.
Okay, great. May I add something?
Sure.
Okay. Being an ophthalmologist, I think it was a wonderful talk. Thank you, Dr. Mishali, for such a comprehensive account of red eye in such a short time. It was wonderful listening to you. Anyway, since it was for the family physician, whenever the family physician comes up with the red eye, they always go on and start with these steroids. And we should definitely, put a warning sign that steroid is not the treatment of red eye. As you have already mentioned, the complications of steroids, because we have seen people going into blindness because of long use of steroids, especially in the vernal catarrh or the spring catarrh. The children, they were once given the steroids. They keep on using steroids for a longer time because the response is quick, and the parents and the child gets clearance of red eye very quickly. So the self-medication and use of steroids, there should be a clear warning that it should not always be used. And as you have mentioned, there are hundreds of causes of red eye, and every cause has a different set of management, and one differs to the other entirely differently. So it has to be an ophthalmologist who should examine it, starting from that the leads to the posterior uveitis and glaucoma and all that. So thank you for a wonderful presentation. I think the warnings and the eyebrows should always rise when you're prescribing medicines the corneal involvement, where the photophobia tells you that the conjunctivitis has involved cornea also, and it's now the keratoconjunctivitis, and the use of steroids at that point will definitely complicate things further. So it is always good for a family physician that if they think that this red eye should be referred to ophthalmologist, it should be done. Thank you very much. Thank you for a wonderful presentation.
Doctor, there's a question from the forum on the group chat. It says that does herpes, you talked about herpes in the eye. So is there a long-term effect which can have post the treatment of herpes in the eye? So I know it is a painful disease in the eye. Herpes is a painful thing. So is there a post correction? Is there a long-term effect which can have a problem, and is there a regular required care which is required?
Yeah, herpes, it can involve the superficial layer of a cornea or the deeper layer of cornea also. So in a superficial herpetic keratitis or stromal keratitis, and it can cause an endothelial herpetic keratitis. So depending upon the involvement of part of the cornea, we need to give a treatment. It may need for a long term, and it may recur. Herpetic corneal ulcer can recur afterwards also. So that again, a patient can present with a similar type of complaint again and again. So sometimes we need to give a prophylactic treatment for 6 months to 1 year also in cases of the herpetic corneal involvement, depending upon the which part of the cornea has involved and severity of the disease.
Dr. Warat,
Cannot hear you, sir.
Can you hear me? Dr. Warat?
Yes.
Yeah.
Yes,
I
sir.
always found
I can hear.
Yes, I always found it useful to keep some fluorescein strips in my clinic, and I can just put it into my eye, into the eye, and then my ophthalmoscope has got a little green light on it, and I found it very useful to detect an ulcer at a very early stage, as opposed to just like Dr. Wazid saying, just blasting everybody with steroid eye drops.
You can use a cobalt blue light of an ophthalmoscope, and once you put a fluorescent inside the furnaces, you can use a blue cobalt light to see whether there is a corneal involvement. In ICU also, we have a great help of the fluorescent strips to see the corneal involvement in the diseases, such as the Stevens-Johnson syndrome.
Excellent.
That's a good,
thank you.
very good way to keep it OPT. Yes. Thank you.
Yeah, thank you. Such a simple, low-tech solution. Okay. Thank you very much. Any other questions from the floor? If not, then I thank you very much, Dr. Warat, for your wonderful presentation. It was very clinically very useful, especially for us non-ophthalmologists. And I'm sure the audience here would also appreciate it very much. And I thank you very much again for participating in our Cmaao talk. Thank you so much.
Thank you, Doctor, for your excellent presentation. We will wind up this session now.
Yes.
We will thank you for everyone for joining in. See you again next week. Thank you.
Thank you very much, everybody.
Everyone, I look forward to seeing